Welcome to Fertility Village. This is your weekly live talk show where community and support come together. With rotating hosts, expert guests, and meaningful conversations, we're here to guide you through the highs and the lows of infertility. Whether you're searching for answers, seeking advice, or just looking for a special place to belong, Fertility Village is your space to connect, learn, and grow. Because it really does take a village, and we are here for you every step of the way. Thanks for joining.
Hello, everyone. Welcome back to Fertility Village Live. I'm Sarah.
And I'm Kaylee. And today we're getting into a topic that we've all obsessed over in the fertility world, which is understanding your test results. Joining us to help decode this often complicated and confusing topic is Dr. Rachel Corradetti-Sargeant, who is a fertility and hormone-focused naturopathic doctor with Conceive Health at Niagara Fertility. Welcome, Dr. Rachel.
Thank you so much for having me.
Thanks for being here. And can we start with just a little background on you? Can you tell us about, how you got involved with helping fertility patients and just a little about yourself?
Absolutely. So I have been practicing at Conceive Health at Niagara Fertility for just about 6 years now. And what led me into that very focused role is my own experience with struggling to get pregnant, stay pregnant. I was actually a patient of Conceive Health myself, as well as it was T-Cart at the time, now Trio. And so I've had, a lot of experience throughout this journey personally, and then now also helping my patients go through this as well.
Amazing. That always makes a difference when our doctors know that side of it.
Oh, yeah.
Patients feel it. From someone who's been there, patients feel it.
Totally.
How does your naturopathic approach to fertility testing differ from the conventional medical approach that people may see, like at the beginning stages?
Sure. So I always need the conventional medical labs, but then I'm usually adding on some of my own added extras that aren't always getting added into the list when you're working with someone strictly conventionally. So I'll be running labs that focus on nutrient levels, metabolic factors, inflammatory markers, so that I can understand if we're missing certain pieces of the puzzle that could be impacting what's going on with the broader fertility issue.
And Sarah and I both know this because we've been through it. It's really like a panic-inducing thing when you get all these test results. Do you have some advice for how to interpret these without getting totally overwhelmed or panicked or confused?
Yeah, it's so easy to go down the Google Chat GPT rabbit
Reddit.
hole. Right, yeah, and I see it all the time with patients in practice. I find that when, you're presented with the information, it's helpful to kind of digest what you've been told and gather your list of questions and see if you can discuss those with your provider. Because often, we can get information about these things on the internet, but the context of your particular experience isn't on the internet, right? So we really need to understand the full story. I had a conversation about this on Monday with a patient who we got the results of her AMH level back. And I think if she had just looked at the number and took that to the internet and went down a rabbit hole, it would have been likely very concerning. But when we're looking at all of the other pieces of the picture, FSH, intrafollicle count, what's going on with estrogen and progesterone levels, we can really fully understand the context of that value as it relates to that particular person. And I try my best when I'm working with my patients to actually spend time going through the results with them. So I'm usually spending about 45 minutes or so going through labs with patients, which is a long time.
In fertility world especially.
Yeah, so I often find that I can, help to clarify some of those issues if the doctor on the team that we're working with doesn't necessarily have the time to go through that. I'll spend more time with patients reviewing that.
I had a naturopath tell me once, so I went for, typical blood work to start. And then redid it when I started to see a naturopath, and my one result came back within the normal range. We love that, within the normal range on the form. So everything looked good. But then she's like, well, actually, like in terms of fertility, it's actually not in the normal range. That's not what we want to see. Can you kind of explain that a little bit? Like why that would happen differently for a naturopath versus like that conventional doctor saying, yes, it's normal?
I think it depends very much on the level, on the lab result, right? So, for example, I'll use vitamin D, okay? Because vitamin D sometimes is tested by fertility specialists, not always, but sometimes. And the reference range is enormous. The reference range goes from 75 to 250. So it's so easy to, get a result back that says, 75 or 76 and like, okay, that's pretty good, right? Okay, maybe. But then let's take a look at what the fertility research suggests. And we see that we often get optimal outcomes. And this applies to other elements of health too, where, vitamin D actually, it serves us a lot better if we can get those ranges somewhere between 100 to 150. That's where we'll often see the best outcomes. So it's very lab specific, where we'll say, you know what, this might need a little bit more work than we thought. Fasting insulin might be another example of that too, where the reference range is quite broad, but when we look at what the research suggestion, we kind of tighten up that number. So it's not in every case that I might say, oh, let's try to aim for something better, but certainly there are labs where that's important just based on what we're seeing from.
Mine was thyroid. Mine was a thyroid one, and I thought,
oh yes, right? The thyroid. Yeah, and you know what? Oh my goodness, the thyroid situation it's a hot topic. It is so heavily debated, and even within the last 6 months, there have been, different guidelines hitting our desks saying, okay, here's what it really should be. And even those levels are kind of confusing those guidelines are hard to understand. So I find the thyroid is always kind of shifting and changing in terms of what we're actually looking for when it comes to optimal fertility outcomes. And what we say is great from a fertility perspective then changes once you're in pregnancy. So it's kind of, that thyroid is kind of a hot mess topic.
I know this is the topic, people. This is the topic. This is the chaos that we deal with and those rabbit holes we go down with. Can you walk us through the key hormone tests that you typically order for someone struggling to conceive, again, as that naturopath, not your typical medical?
And they really won't vary a ton from what you'll see conventionally, right? So, if we're talking strictly about hormones, day 3, if a patient is cycling regularly. If not, then I'll just do a general look at hormones, but I want to understand FSH, LH, estrogen, prolactin, TSH, so thyroid function. Androgens, sometimes I'll do a bit of a deeper dive on androgens if I suspect a patient may have an issue with polycystic ovarian syndrome. Sometimes I'll see in some fertility clinics, they may only test one value. I'll tend to test 4 different androgens just so I can get a full picture. And then AMH can be helpful as long as it's interpreted correctly. So, and then of course, if the patient is cycling, then I would like to understand what's going on with progesterone levels as well. So I'll try to accomplish that 7 days post-ovulation to get a sense of what that number is, and if it's, adequate. And so the one hormone that, again, I don't always see this tested at every fertility clinic, it just sort of depends, but fasting insulin is another hormone that I'll generally take a look at, just to get a sense of what may be going on with insulin resistance, even outside of a PCOS setting.
When you said day 3, like a lot of your tests are done day 3, can you quickly touch on that?
Sure.
Why day 3?
Yeah. So this is where if I could, I would bring up that like beautiful picture of the menstrual cycle from, at grade school health class, right? That everyone just totally wipes, right? Like we just wipe it from our brains because we're so embarrassed, and then wind up in my office and I'm like, here it is. Let's talk about this. So the beginning of the menstrual cycle is the quietest, essentially. And so it's a really good time to pick up on some of these hormones, because if the labs are off at that very quiet time in the cycle, then that's going to indicate that something is amiss, right? So for example, with FSH, follicle stimulating hormone, that hormone is just starting to, get engaged in the game at the very start of a menstrual cycle, when that hormone will call upon a follicle to start to mature in the ovary. So if we see at the beginning of the cycle that FSH levels are really high, it tells us, well, the brain is working really hard to try to get a follicle engaged in this maturation process. Why? Like that shouldn't be happening right now. It should be, kind of just a gentle moment in the cycle. So so that's why it's a good time to pick up on definitely FSH, LH, estrogen levels are really important to understand on day 3.
So you sort of started to pick up on this question, but like when people are struggling with infertility and come to you, is there a typical hormone imbalance that tends to come up more than others, or a few that crop up often?
Yeah, I mean, 75% of my practice is PCOS patients. So
Wow.
It's hands down. Yeah, it's really common, right? And it's poorly diagnosed. It's poorly understood in some cases. And, I think that can be troublesome, right? I had a couple in today, and the woman was told she has PCOS, but when I looked at the labs that had been done with her referral, I was like, well, nothing in here really suggests that. So how are we diagnosing this exactly? And, we have to kind of start fresh. So, and then even just the name alone, I mean, polycystic ovarian syndromes, my patients think, I have a bunch of cysts on my ovaries. And then they ask me about, bursting cysts and things like that. I'm like, okay, now we're talking about 2 different things. So it's confusing, but yeah, about 75% of my patient population has endometriosis, and thyroid issues are definitely in there too. So I would say that's probably second. Yeah. Most common.
You've got your whole patient population here.
Yeah, just right here.
Yeah.
So, and then, it kind of goes down from there in terms of getting into cases of lower ovarian reserve and, conditions like endometriosis and that type of thing. So I'm the low ovarian reserve person. So now we've like the whole
got it all.
group is here. Yeah.
That's it.
You mentioned the PCOS thing, but and that it's often misdiagnosed. Could you speak a little bit to like what people should, like what are little markers that people could pick up on when they get their tests back and say, oh, like maybe this is something I should think about?
So we always go back to the Rotterdam criteria, which are the basically the checkpoints that we need to hit in order to diagnose PCOS. And so if we're looking at sort of like the original Rotterdam criteria, we need 2 out of 3 things to say, yes, this is PCOS. Okay. So one of those things is a polycystic appearance of the ovaries on ultrasound. Okay, so that, we call it like a pearl necklace appearance, or, we're going to see multiple follicles on the ovary, usually greater than 12 per side. And we'll say that's a PCO appearance. That's one thing. If we see that, okay, check the box. The next thing that we'll look for is whether or not the person is ovulating. So sometimes if they're having an irregular cycle or they have, absent cycles, we can surmise that they are likely not ovulating. We can test progesterone levels to help confirm that as well. So if we're seeing, okay, progesterone levels are suboptimal, we can kind of check the box and say, okay, we have 2 out of 3 pieces of criteria here. We can say that this is a PCOS situation. The third thing that we tend to look for is what's going on with androgen levels. So androgens are male pattern hormones typically, but as females, we'll have them within us, and they're really important in the creation of estrogen as follicles mature. But if testosterone levels, just to speak of one androgen in particular, testosterone, if those levels are too high, then it can shut off that follicle maturation. And so we'll look at androgen levels on labs, but we can also look at androgen levels at, with clinical presentation. So does the patient have acne? Does the patient have abnormal hair growth on the face or body? Does the patient have hair loss? Those can be some signs that show that it's going on, even if we don't see the actual elevation in androgens on labs.
That's what I got. It was very like minimal, my symptoms. And so I went through a whole round of IVF, and prior to that, you know, the IUIs and the natural cycles and all those things, all those monitoring. And it wasn't until my second like IVF clinic that she finally looked and she's like, these are kind of showing PCOS. Have you talked to like a naturopath that specializes in fertility and things like that? So it was really interesting. It took a long time for even, and I don't think I ever got the full out diagnosis. It was just suspected. And so the more I look at those symptoms, I'm like, oh yeah, right?
Yeah.
Those minimal symptoms that don't necessarily show up on the tests every month. So that's really interesting that you shared that. And then you talked a little bit about like the male hormones, but what are some of the tests you recommend for male partners? And is there any hormonal imbalances there that you see?
Mm-hmm. So if I can, I like to see FSH levels for males as well. Testosterone for sure for males can be really helpful to understand. It's amazing how often I see testosterone be like suboptimal for males. And a lot of that comes down to lifestyle factors for sure. Prolactin can be a helpful one to assess. And sometimes I'll also add in LH and estrogen for males too. Yeah, so those are the hormones that I'm typically looking for. I'll run insulin for males. I'll run TSH for males too. So that, that's a pretty good panel to run for a male patient just to get a full picture of things.
Okay. Is there any mentioned things that you see? Sorry, is there any common ones that you see that are often males more often than others? Like you talked about how females, it's often PCOS or endometriosis. Is there any males that you normally see in your test?
When we're talking specifically about hormones, you know what, interestingly enough, I don't see males having a ton of hormonal issues on labs. You know, from time to time, we'll see something strange going on with TSH. You know, from time to time, something going on with prolactin levels. But I will frequently see just like a slightly suboptimal testosterone, but that doesn't necessarily play out on what I'm seeing from a sperm analysis perspective, right? So usually if somebody has low testosterone, we think, okay, well, then they're going to go ahead and have, not a lot of sperm either. But I don't always see that connection. So yeah, that one's a little bit interesting. But I would say more so what I see for males is a lot of like metabolic issues and nutrient deficiencies that seem to be playing into poor quality sperm as well. I see a lot of poor quality sperm. I would say a majority of my male patients have poor quality sperm. And I don't know if that's location specific. We are, our practice is in the Hamilton area. So we have wineries and farms using pesticides. We have refineries, right, with the steel factories here in Hamilton. So I don't know. This is my sort of like theory is that that's impacting things. It's very possible, but yeah, unfortunately, sperm quality is not great these days. What we're careful.
Is there anything that men can do to improve that? I know that there was a lot of talk of CoQ10 when I was going through things.
Yeah, that's definitely helpful. It's an antioxidant, so it's going to support the mitochondria function within the sperm. And so that's like the engine, the kind of energy factory of the sperm. And then it will also impact the genetic material within the head of the sperm, so the DNA. So CoQ10 can be great, and we can see it really impact morphology or the shape of the sperm. It can impact also the motility of the sperm. As I mentioned already, working on nutrient deficiencies, working on, blood sugar dysregulation, dyslipidemia, those type of metabolic issues can be really important for improving sperm health outcomes. Controlling for toxins that are potentially like social toxins. So if a person is smoking, drinking excessively, if they're using recreational drugs, especially marijuana, that's a huge no-no for sperm. It's really impactful. Overheating, so in particular jobs where there's a high level of heat, that can really impact sperm quality. So trying to control for those factors. And then if we have factors that we don't necessarily have control over, so like I said, some of those environmental toxins, that's when we can get more heavy-handed with bringing in antioxidants like CoQ10, agents like L-carnitine to assist with motility, vitamin E, selenium, zinc, there's a lot. There's a lot. So there's a lot that can be done to improve sperm quality for sure.
That's good to know.
Mm-hmm. Yeah.
Not all is lost.
No, I find most things in the fertility world are figure outable. And that's what I try to remind my patients is like, we have to figure it out, and it's going to be overwhelming because we might find a bunch of stuff, but most of these things we can figure out and improve.
It's so nice that you said that, actually, because I had actually one fertility doctor tell me, like, well, some things we just can't figure out. They're just on such a micro level. We'll just never really know, or the science isn't there yet. But I kind of agree with you. I think a lot of things, there's answers out there. You just have to look for them.
Yeah. And no doubt there are some fertility cases where, my goodness, it seems like every single stone has been unturned and success seems to evade us. So there absolutely are those types of situations that I think that exist really in any sort of situation, right? Absolutely. But a lot of, the cases that I see come across my desk are, we can figure things out and we can improve. And what's remarkable about, having a diagnosis of infertility, I find it really triggers a bit of a health journey for people. Yeah. And we find things that, people needed to know about their health. And you're learning this at a young age, right? So we can make changes, we can change habits, we can change lifestyle. And so not only are we working towards you becoming pregnant, staying pregnant, having a healthy pregnancy, impacting the health of your child, right? We're also keeping you alive and well and healthy so that you can be present for your child too. So it's really, it's an important journey often.
Yeah,
absolutely.
Mm-hmm. Can we dig into the AMH and FSH of it all a little bit? Just because these are numbers that come up so often for people, and the big scary numbers. Mm-hmm. Could you just explain what they really mean and how they fit into the bigger picture?
Little scary numbers.
We're little scary. So, my AMH was a very little scary number. So I feel that pain. AMH, anti-Müllerian hormone, is essentially a value that can help us understand ovarian reserve. So, how many eggs are left in the bank, you might say. It doesn't tell us about quality. I do have to remind people of that quite frequently. We don't really, at this point, have a way of knowing about quality until we're literally, some of these eggs have been retrieved and we're looking at them under a microscope. I know that technology is developing, but we just don't have that as readily available as we do with, blood tests and things like that these days. So, AMH, simple blood test, we can find out what, might be going on with that level of ovarian reserve. It's a number that can be interpreted by age. So there are different reference ranges for age. And then it can also be interpreted just by number alone, and it'll fall into categories of, very low ovarian reserve, low, medium, high, very high. And so that's something I'm always trying to do with my patients, is just help them to understand, okay, perhaps your AMH is falling into a low ovarian reserve category, but also you're 40. So we would expect you to have a low ovarian reserve. And so then what becomes important now? Well, let's take really good care of the eggs that are there, right? And make sure that they're excellent quality. Values like FSH can help us interpret the AMH, or I should say perhaps the impact that AMH is having. So if a patient has a lower ovarian reserve and the body is starting to get a little bit stressed out about that, then FSH levels will start to climb higher because, as I mentioned before, the brain is working harder to try to get the ovary to do its thing. And so that can sometimes impact how well a person might take to a fertility treatment. And it can impact, it can indicate that person might be starting to enter into a bit of like a perimenopause phase of their life, depending on the severity of the level.
That's awesome. Yeah, I have two questions. First one, can AMH be too high?
Yes. So we do see a high AMH in PCOS cases, right? So generally if we're seeing, depending on the units you're using, but if we're talking about like a p mole per liter unit and we're seeing AMH above 48, that can indicate that the patient may have PCOS. Or if we're seeing very high numbers for that person's age. So I had a patient this week who actually had an AMH of 46, but that patient is 38. So that was quite, dramatically high for their age. And so that can sometimes be indicative of PCOS because, at the root of it, essentially, they're not like burning through their follicles, right? Like there's still lots of eggs there because they haven't been ovulating them, right? So, yeah.
And back to that PCOS, we had a viewer question come in.
Mm-hmm.
Can someone be borderline or have acute PCOS? Is there a difference like grading like with endometriosis?
Good question. So yes-ish. I wouldn't say that's something that's being like written down, right? But I'll see it in patients where I'll say, wow, I think you have a PCOS tendency, or, this is kind of like a borderline PCOS situation. And if you didn't take, such good care of yourself with your nutrition and with your, your physical activity and those types of things, that this might go into like a full-blown PCOS situation. Acute PCOS, so sometimes we'll hear about like a post-pill PCOS, like people coming off of their birth control and that sort of presenting like a bit of a PCOS picture. So I've seen that in some cases too. So that might be the best way to answer that question.
Is that like they're not quite ovulating because they're not?
Yeah, because things have been kind of suppressed for a while. And
Okay.
yeah, so, depending on how long they've been on the pill, do they have a higher ovarian reserve because they weren't ovulating for however many years? And so, yeah, so it can just look a little murky sometimes in those early months coming off the pill. And then people who have PCOS who are on the pill come off the pill and their androgens are suppressed. So they often just function normally, which is interesting. Yeah, so hormones are just so fun.
It's true.
It's not confusing at all.
No, not at all.
It could be this or it could be this. It depends. Everybody's story is different. That's
It
for
is.
sure.
It's so everyone is so individual, and like you just can't apply like general statements. I find in often cases in fertility medicine, because it like every case that hits my desk, I'm like, okay, we've got this. People say, well, what are your statistics and what are your success rates? I'm like, it's so hard for me to answer that question because I have no way of saying this couple versus this couple, and you know what I mean.
Yeah.
So,
It's apples to oranges, right?
it totally is. Yeah, absolutely.
We hear a lot about inflammation during testing and infertility. What does this mean, and what kinds of tests show inflammation?
Great question. Not many, I would say, is the answer. And even running some of the inflammatory tests is a bit of like a hotly debated topic. So I'll sometimes run something called CRP, which is C-reactive protein, which is kind of like a general inflammatory marker. And so, yeah, sometimes it can show if we have inflammatory stuff going on within the body. But it's so general, it doesn't necessarily point a finger at one thing and say this, right? So, maybe you're inflamed because you were sick. Maybe you were inflamed because you had an injury. Maybe you were inflamed because, your uterus is full of fibroids. It's hard to interpret it sometimes. And so sometimes it's telling us that the inflammation is there. Then we need to work on it, but we don't necessarily know where just yet. Yeah. So inflammation is common, and it's a little bit kind of tricky because you have to try to figure out like, well, where is it coming from so that you can go after it more directly versus saying, oh, here, take a curcumin and off you go. Mm-hmm.
And then we talked about thyroid a little bit earlier, but can we dig deeper into that? So what does role does the thyroid take in fertility? And then what markers do you look for most closely?
Yeah, great question. So thyroid the thyroid gland sits here. Hopefully that's not messing with my sound, but right on the kind of front of your neck, like a little bow tie or like a little butterfly. And it's essentially there to set the metabolic rate of your body. Okay. So it's going to receive messages from your brain. Specifically, the hormone is TSH, or thyroid stimulating hormone. I'm sure you've seen that in lab reports of your own before. So that hormone is coming from the pituitary gland, which sits kind of between your eyes, behind your nose, just kind of underneath the little frontal part of your brain here. And it's going to stimulate the thyroid to do its job, essentially. Okay. And so then the thyroid is going to produce hormones that then go and tell the other organs and systems of the body how quickly to operate. Okay. So I kind of think of it as sometimes like you're driving a car and you're the driver sitting in the driver's seat and you have your foot on the gas and you decide how quickly does the car need to go or how slowly does it need to go. And so, that's kind of like you as the brain operating the engine of the car to make the systems run faster or slow the systems down. So if we're talking about, well, what does that mean for a fertility situation? The menstrual cycle is a very energetically demanding process and it requires a set rhythm and rate essentially. And so if the thyroid is misbehaving, if it's under functioning, that can impact how the menstrual cycle, then functions and can delay things. So we'll see in some cases if there's a thyroid issue that the ovulation might be delayed, or the patient isn't ovulating in some cases. We might see that the progesterone levels aren't as great as they could be, just like under functioning overall, some sluggishness within the body. And then in a pregnancy situation, in the first trimester, the fetus is relying on the mother's thyroid to run the show. And so we need to make sure that the thyroid is functioning optimally in early pregnancy too, so that we can support a healthy pregnancy.
It's amazing, that little thyroid.
I know. It's so fascinating. Yeah.
When they said oh yeah, it's not optimal for pregnancy, when I got that test, I thought, oh, that's really interesting. I had no idea that it was so important, really, right? To watch those optimal levels.
Absolutely. And it's hard to get it looked at sometimes. So we talked about, what numbers do we look at? So we look at TSH. We can look at T4, which is the main hormone that the thyroid produces. And then in some cases, we'll also look at thyroid antibodies. So these are basically immune system mechanisms that are acting against the thyroid. They're testing that or not testing that right now. It's kind of a bit of a debate because the guidelines are suggesting that it's not necessarily as important, especially if the TSH level is normal. Mm-hmm. So yeah, that I still tend to look at it for my patients just because I want to address it just from an overall health perspective too. But sometimes it's not being addressed as often in a conventional setting.
This one relates so much to me because they say I'm pre-Hashimoto's. So I have the antibodies, but the TSH is normal.
Yeah. So that's
on my way.
Yeah, it can be frustrating in that situation because then it's like, okay, well, do we have to do anything about it? And looking at, for example, the decision of bringing in like a thyroid medication. I mean, technically, no. If your TSH is good, then, Synthroid isn't necessarily indicated. So it really, for me, sometimes it has to do, well, how is it impacting you? What's going on with your health experience? What's your fertility story? In some cases, I might do things to address it. And there's a lot that can be done to address thyroid antibodies that are pretty simple. I mean, the internet will tell you don't eat any gluten and dairy, which is unfortunate because, that's not where all of the evidence lies. We can do a lot with even just optimizing vitamin D and, making sure you're getting adequate selenium. Certain doses, I'll try that again, of inositol can be really effective. And then also have other fertility benefits too. So there's a lot that can be done to kind of stabilize those antibodies. And, the hope is that then we don't wind up in a situation where those antibodies are kind of blowing out of control. And then we do have a TSH problem.
Right?
Yeah. So that's
I'm going to go off script a little bit here. And when you are checking your patients, how often are you getting them to come back and redo those blood works to find out where that optimal numbers lie for them?
Yeah, good question. So It depends on what we're looking at. Most of the time, if I'm trying to mess with something in a good way, I want to see people back within about 3 months. That's generally how long we need to see something change. In certain cases, if I'm like really trying to stay right on top of something, like sometimes this will apply, for example, with insulin levels, which can change rapidly when we're doing, good work. I might say, you know what, let's look at this in like 6 to 8 weeks instead. But most of the time we can see pretty positive change within 3 months.
That's awesome. And it goes back to this, our next question, which timing matters. So we talked a little bit about how you do a lot of the testing on day 3, but I know I've had testing done at other times in the cycle. So why does that matter? Like, why is testing at the beginning? You said because it's, again, that's when it's quiet. Why would testing be done later in the cycle?
So early in the cycle, because we're going to get your baseline, and that's what we're going to kind of understand. Okay, is everything well at the beginning? Check. Cool. Next, is that patient ovulating? So that's when we'll look at doing sort of mid-luteal phase testing. If you're doing cycle monitoring, then your fertility team is going to be looking at your hormones throughout the follicular phase, just to make sure that you are responding appropriately, that your estrogen levels are climbing in the appropriate way while your follicles develop. They'll want to watch for, what's going on with your luteinizing hormone levels to make sure that you're not, surging too early, or, that they're going to miss that ovulatory moment. So yeah, that's why you'll tend to have those types of tests done throughout like an actual fertility treatment cycle, because it just informs your team about how you're responding to, whatever medications are being used.
And so this next question applies to me. I was unexplained for a really long time. And I had normal on every test, but nothing was working. So are there any lesser known markers or functional tests that you recommend for people who are kind of hitting a wall?
Definitely making sure that some of the things I mentioned early on are getting looked at. So, did we look at nutrients? Did we look at metabolic markers? Did we get a sense of what's going on with those? Because sometimes that can indicate things. We're having a bit of a chat these days about what's going on from like a microbiome perspective. So that, conversation about, okay, well, what do we have, any sort of infections going on that we aren't aware of? Do we have enough lactobacillus within the uterus to support a healthy pregnancy? So those are some of the lesser known, well, I shouldn't say lesser known, newly discussed and also hotly debated topics in the fertility world. So we can talk about those things. Sometimes if we're looking at like a recurrent pregnancy loss situation, there are more specific tests that can be run to look into sort of, are we dealing with blood clotting issues, autoimmunity, factors that could be going on. So sometimes we talk about like immune system acting up. That can sometimes creep into the infertility space as well. So those sometimes get a little bit more complicated, but those are some of the other things that can be looked at. Was endometriosis worked up, right? Do we have a clear picture of whether or not that exists? And then oftentimes we'll say, if it's truly, we've looked at everything and we don't seem to have full clarity, then the one thing that we have a hard time looking at is egg quality. And so sometimes that can be what's going on.
Right. Yeah, it's the fertility world just changes all the time, and it's kind of nice to see those new, studies that come out and people thinking out of the box of the things to check and look at, because again, it could be those little things that maybe 10 years ago, 5 years ago, 2 years ago, people didn't know. And I say this, I think every live is every time I do a support group, I learn something new because there's a new test or there's something new to look at. And again, it just helps our support group members when they're going through it to ask their naturopaths and their doctors about like what's happening, or can we do that test? I feel like there might be something there. So it's really fun to listen to those new things. But yes, they're always hotly debated, right? Because it's new and it changes so quickly.
The latest one seems to be cortisol. That I think must just be a TikTok or some sort of trend, because I have a lot of patients coming in asking for cortisol testing. and feeling concerned that that's what's impacting their success. And I mean, that is just, oh.
What are your thoughts about that?
Yeah, I mean, I think right now, Instagram and TikTok seems to be telling everybody that they have cortisol issues. And I think that's probably a little bit overrepresented. And it's a hard thing to test. I mean, I can think of one case in my 11 years of practice where I tested someone's cortisol through blood work and had an abnormal result. Like, I just don't see it very often in blood work. So it's a hard thing to test. And then, so then we talk about, you know, the more like functional tests that you can use to pick up on cortisol. So there are saliva tests, there are urine tests, but, you know, what evidence do we have that these are like super valid tests? And, you know, so that one is a little bit tricky, but it seems to be a hot topic. So I'm sure.
And then what treatments, like, are there treatments for cortisol imbalances?
I mean, if you have a very severe problem with your cortisol, then there's something going on and you need to be with an endocrinologist and get that treated, right? But if we're talking about, you know, managing stress, I mean, sure, there are lots of things we can do to manage stress. I don't know if we necessarily have tests to like say, yes, you are stressed and this is the impact. More so it comes in your, you know, case taking and chatting with the patient and, you know, what is going on with stress and is it impacting your daily life and can you sleep and are you anxious? And, you know, if we're getting yes to a lot of these questions, well, we should probably work on that, right? Because, you know, that's going to make everything a whole heck of a lot harder. Yeah.
I wonder if part of the genesis of that trend is like, we always get this comment in the fertility world from non-fertility people of like, well, maybe you're just too stressed and that's why you can't get pregnant, which is a huge peeve for a lot of us.
Such a damaging statement, right?
Yeah.
I mean,
of course I'm stressed.
Yeah, like who isn't, right? I mean, and then it's even in the research, like it's not even clear stress causes infertility. No, like stress and infertility go hand in hand, right? We're not saying that there's like, you know, causation there. There's correlation. There's not causation.
Needles are stressful.
100% go. It's like fitting in. How am I going to get there? At what time? They're going to tell me.
Violating tests, all the things.
Yeah, right?
All like, stressful. It's one big ball of stress.
100%. So, I mean, people are stressed. When this, it just is the case. So then how do we manage that, right? Like, what are the things that we can be doing to try to make it manageable in someone's life and not overtaking? You know, and I think that's sometimes something that doesn't even get discussed very often is that, you know, if a journey is going on for a while, it's hard. And people aren't necessarily getting asked that, right? Like, how are you doing? How are you holding up? Do we need to start bringing in more support, right?
And that's where 100%. That's where we came from is we just felt alone, and finding our people just made a huge difference in relieving some of that stress, believe it or not, and being able to vent to people that understand. And again, that's a big, big part of our prerogative. That's for sure.
Yeah, that's
absolutely
so valuable, because, you know, when I go and get a patient from the waiting room, no one's talking to each other, right? Like everyone's just in their world. And I get that. You don't necessarily want to make friends in that moment. But I think there is there's something different with the online space, right? And so I think that's something that's so unique about this particular situation. And I know not all of the meetups are online, but it's I think sometimes nice for people to be able to be in their safe space, but then also connecting with others, right? Yeah,
absolutely. It's great. We are grateful for all the people that come through our door. And again, the hardest part is getting there. So we always say like, come to just one, you'll see. And again, most of the people that said like, why didn't I find this sooner? So again, that safe space for people does make a difference in their stress levels, which is good. We think it's good. So if we can hold some of that stress for people, we're happy to, that's for sure. Can you share a patient example, of course, anonymously, where interpreting test results holistically made a significant difference in their journey? and in their outcome?
So many. Like the first one that's coming to mind is the thyroid case, of course. I don't know why, because I just want to be controversial today, apparently. I don't know. So yeah, I think it was a case where a patient had a TSH level that was only slightly above the normal reference range. And so their medical doctor wasn't feeling too concerned. And then I brought it to the attention of the fertility doctor and just said, FYI, in this patient's history, they were put on Synthroid. And that is the only time they had, been able to get pregnant and then stay pregnant. So, would you be willing to potentially try that and see if it works in this case? And so that was, something that was agreed upon, and the patient began that and was pregnant like the next cycle.
Wow.
Yeah. And so, yeah, it was really just one of those moments. I was like, okay, well, every once in a while, we kind of gotta sometimes, just push the envelope a little bit.
Must be very rewarding when that happens.
Yeah, it's nice. And I think that's one thing that's quite fascinating about the experience with Conceive Health is that we work with the medical doctors quite closely. Right. So we get to have these conversations and build these relationships where, it's like we're not trying to be a pain. We're just trying to advocate for the patient and maybe look at things in a slightly different way. Right. So it's nice to kind of have that open communication, mainly for the patient, right?
Yeah. That actually leads right into our next question, which is like, if you feel something isn't right, sometimes it's hard to bring that to your doctor and to feel heard. Do you have any advice on like advocating for yourself in that space?
Sure. So it is challenging if someone's coming in and saying, I saw this on Instagram, or I heard it on a podcast, sure. Or you know what I mean? Like sometimes right away, like it can be like, oh, wow, this is not going to be valid, or how do I, So sometimes it's helpful to say, I've noticed this about myself, or this is a symptom that I'm experiencing. And, is there a way that we might be able to look into this? Like sometimes that allows your doctor to still feel like they're helping and not you just going to them and saying, what about this? And you didn't do this. And, how come? And that type of thing. So sometimes it would be kind of nicer to come to the table and say, well, I was doing some research on XYZ things. Can we chat about that? Like, what are your thoughts? That type of thing.
That's great advice. We have another viewer question, which also leads into our next official question. Okay. So our user's asking, since they have PCOS, they say are having PCOS, but it can result in more egg retrieved. For the record, I had PCOS and I had lots of empty follicles. So that's my little thing. So it doesn't always you don't always get more eggs. You get more follicles, but not always more eggs. Yeah. And the quality can be bad. That's for me. So should they look into curing or managing the PCOS after retrieval or before? And then what lifestyle or dietary changes, because I know this goes hand in hand with it, will you recommend based on those patterns you see in hormone testing, such as PCOS?
Yes. So, okay, let's go back to the cure question. So cure is not really a thing with PCOS, right? It's very much kind of like a lifelong thing. So it can be managed, right? And it does have big impacts on metabolic health long-term and longevity. So it is something that you can manage. I think that's a better word to use than cure. Mm-hmm. So do you want to manage it before going into an egg retrieval? Ideally, because I'll find, for example, that my patients may, have a similar situation to what you're mentioning, Sarah, where they're getting a big response, but we're not finding that, there's a lot coming out of that, right? Or in some cases, and I've seen this more so in cycle monitoring in like IUI situations, patients just aren't responding, right? Mm-hmm. So there's that component as well. So yeah, if we can address it beforehand, awesome. And so then, but if we're in a situation where we haven't been able to, and, we're thinking about moving into a transfer, absolutely, let's address it before you go into a transfer, because there are components of PCOS, especially if it's insulin resistant based PCOS, that can then impact the health of pregnancy and put a patient at a higher risk of, something like gestational diabetes. So yeah, there's stuff that we'll kind of take it wherever we are. If we can do it before, great, but afterwards is great too. And with respect to what can be done, so much. It is generally specific to the case, right? So not all, if we're talking specifically about PCOS, not all PCOS is insulin resistance based. So, but if it is an insulin resistance based case, then yeah, we're going to talk about the dietary adjustments that are helpful. Protein, right? Adequate protein is definitely really, really important and is a struggle for many. And I will have that conversation even with patients who show me a beautiful diet diary. And I'm like, yeah, this looks lovely, but I'm not sure you're getting enough protein still. Let's talk about that. Let's learn what that number is together and talk about how we can work on it. Fiber is another big one too, right? And those two together will work very well to help manage blood sugar levels and, often support better outcomes. So there's a lot that can be done. Absolutely getting the body moving is really important. I'm not one to say you must do this type of exercise. More so I'm focused on, can we just get blood flowing? Any way we can get blood flowing through the body and bringing, nutrients to the reproductive organs is great. I don't need you to be a CrossFit junkie. In a lot of cases, I'd rather you not be one. But, I just need some sort of activity going on. Yeah. Yeah. So there's quite a bit that can be done. And then, there's the conversation about nutraceuticals as well. So looking at things that we've talked about inositol already, but N-acetylcysteine, there's a place for that. Sometimes we'll use botanical medicines to help with managing some of the androgen levels if that's more of the issue with the particular PCOS case. So yeah, there's quite a bit out there for managing. Again, coming back to that idea of things being like figure outable, right?
Mm-hmm. Yeah, and I found it really effective, specifically when I was working with a fertility specific naturopath, it's little things that make big difference, right? It doesn't have to be like take all these supplements and do all these things and run an hour a day. Like it was just the very little minor things that really affected my overall health and my treatment and all the things that came with it. So I like naturopathic medicine. So
good. Glad to hear it. Me too.
Good. That's good.
Yeah, right? Maybe I wouldn't have said that at 3:00 this afternoon, though. I was on calls from 7 to 3, without a lunch break today. And I'm on vacation next week, so that's part of the reason. And I was like, I don't know if I like this right this minute, but I will like it later.
Right. Absolutely.
Yeah. Sorry, you were mentioning.
We had another viewer question, sort of a question. I'm hoping you can put this person's mind at ease a little. Okay. They mentioned how they've had stress during stimulation and they're not sleeping enough and they're really scared because maybe this is going to affect their egg quality.
Oh, right. Okay. That's a lot of pressure on yourself, right? So that is, egg quality is a multifactorial situation. So does getting good sleep help? Sure, but it's not the only thing. There are other things that impact that can be worked on to kind of take the pressure off that one particular factor. Right. Interestingly enough, something that helps with sleep also tends to be amazing for egg quality, and that's melatonin. Not that I'm telling that person to take it because you are not my patient, but that would be worth chatting about with your healthcare providers to see if it would be effective for you and appropriate. But little tip there. So yeah, and then it would be a matter of, well, can we look at the ways that we can actually help with a better quality sleep? So I talk a lot about sleep hygiene. Right. And that doesn't mean just cleaning your sheets, although very important to do that. What is your bedtime routine? When is the phone going off? Do you actually allow yourself to stop being constantly mentally stimulated, let alone ovarian stimulated? Like, is the mind calming as well? Because, if you're going to bed at night and your phone's here and you're doom scrolling, it's going to be really hard to fall asleep. And it's not going to be a good quality one either. So yeah, but it's hard to just blame. I wouldn't blame it. I wouldn't blame poor outcomes on you not getting enough sleep alone. Right? That's a multifactorial thing. So.
Right. And is it possible for your egg quality to be impacted? Like you're in a stimulation cycle. You're taking the drugs, about to have your eggs retrieved.
Yeah.
Not sleeping so well, feeling a bit stressed during that moment. Is that directly, that's already sort of predetermined before you get the cycle, correct?
Egg quality is like 100 days ago. So, right?
Thank
you. Thank you. Helped me answer that question better, Kaylee. So yes, egg quality is something that's happening, months before we get to the actual egg retrieval moment. So having issues in the cycle itself, it stims 2 weeks. It's not the end of the world.
Yeah. And also we're all stressed during that. There's no person on this earth who isn't, I'm pretty sure.
No, definitely not.
And uncomfortable and all the things that go with it. That's
absolutely.
Bruised and bloated and.
Yeah. Yeah, that's hard.
So final question for you. What is one thing you wish every fertility patient knew about their test results?
Oh, that's a big one. What do I wish they knew about their test results? That it's possible there might be some things missing that aren't telling the full picture. That maybe is what I would say. Yeah, being in this world now for, it's been almost 6 years. If I think about my clinical work specifically, that's kind of that, my own experience was sort of before that. So I've been in this world for a while, and many different fertility clinics in the province of Ontario, and there do seem to be different approaches to testing. And so I have seen in some cases where patients are coming in with their results, and I'm thinking, I think we're missing something here. Mm-hmm. So making sure that we're adding things in and looking at as many things as possible to make sure that we have the full breadth of the case.
Great advice. That's awesome. Mm-hmm. That brings us basically to time. So I want to thank you again, Dr. Rachel, for being with us tonight. You've shed so much light on those scary test results and opening people's eyes to what they should ask their doctors and things to look at. So thank you so much for clarifying that for us. I know that's going to help a lot of people in our community, not just tonight, but all the people that are going to watch and listen to this in the future. Everyone can catch this again on our socials, on our YouTube channel, and you can check out our podcast page for the audio only version of this Fertility Village live this evening. So thank you again. We also want to remind everybody that our next Oasis support group is coming up this Monday evening. So don't forget to go online and register to find either an in-person location near you or our online virtual support groups. I will absolutely see you there. And as well, this is our last month to get our new fertility help journal called I Can Do Hard Things. It's a fertility journal. It's completely free until September. You can go on our website, get the link. We'll send it to you free. If you join our support groups following that, we'll give you the codes for it. But we will hopefully see you on Monday and next Wednesday at the next Fertility Village Live, and Kaylee and I next month. So thank you again, everyone, for joining us. We will see you next time.
Thank you so much.
Thank you.
Bye.